Good afternoon, everyone. So I'm Chitra Bama. I'm a PhD scholar at PGI ChandiGrah. My topic is comprehensive evaluation of cytogenetic signatures of product of conception from recurrent pregnancy loss in North Indian population. Recurrent pregnancy loss is basically defined as two or more clinical losses of pregnancy before 22 weeks of complete gestation. It affects about 1 to 5% of couples worldwide, and nearly 80% of the losses they occur within the first trimester. However, there is lacunae of data from the Indian region, and it is believed that the spontaneous miscarriages rate is much higher in the Indian population as compared to the Western women. Therefore, since the underlying etiology is very complicated, and it makes RPL one of the most frustrating and difficult areas in reproductive medicine. Therefore, because of the results are ineffective, because of the ineffective diagnostics and treatment therapy, it is a major burden for the couples who are planning family. Thus, we believe that determining the etiology, prevention, and treatment of RPL are of vital importance for human reproductive health. With this, we have come to the etiology. There are some known factors for RPL, which include some uterine anomalies. There can be some autoimmune factors, endocrine factors, infections, genetic factors. However, in 40 to 50% of the cases, the etiology is still unknown. So, among all these etiologies, we believe that the chromosomal abnormalities and the genetic imbalances in parents, as well as in the fetus, they have been recognized as one of the major causes of miscarriages. Now, worldwide, it has been observed that approximately 2 to 8% of the couples who are suffering from recurrent abortions are because of some chromosomal abnormalities which is present in those couples. Also, it has been noticed that the embryonic chromosomal abnormalities has been seen in 50 to 60% of the early pregnancy losses. Among the chromosomal abnormalities, the aneuploidies are the most common among the embryos, and up to 90% of the chromosomally abnormal embryos, they are spontaneously aborted. And if we look at the common aneuploidies, it includes the chromosome 13, 18, 21, and followed by the X chromosome monosomy. So recently, there has been an attention on the submicroscopic chromosomal variations, which are also being referred to as DNA copy number variations, which have been found to be susceptible in RPL. Thus, and along with the CNVs, because of the newer molecular cytogenetic technologies such as chromosomal microarray, it has brought this prospect of greater diagnostic resolution. Now, CMA, it can detect imbalances as low as kilobase pairs in size, and it has shown superiority over the standard karyotyping method. So this brings us to the rationale that detection of CMVs in the product of conception samples will help to identify the embryonic chromosomal abnormalities, and it will aid us in understanding the etiology of RPL. Further, early recognition of the potential risk to pregnancy losses and systematic monitoring will have a beneficial effect in increasing the live birth rate in such couples. With this aim, the study was conducted to evaluate the cytogenetic signatures and product of conception from the recurrent pregnancy loss patients. Our primary objective was to identify the chromosomal abnormalities and CNVs in the POCs of RPL patients. And secondary objective was to analyze these breakpoints of detected chromosomal abnormalities to identify the potential miscarriage-associated CNVs, candidate genes, and their function in RPL. So the inclusion criteria we had that the patients who had history of RPL, more than 2 consecutive losses, which were being clinically proven by ultrasound or some pathophysiological examination, and we included the first and second trimester losses. However, we excluded the patients who have undergone pregnancy using some assisted reproductive technology, patients with autoimmune or metabolic disorders, and patients with history of preeclampsia. We expected the outcome that this study will provide us data for the genetic etiology of aborted fetus and provide information for the future pregnancies in such cases. So we recruited couples with history of RPL, and when the ultrasound showed no fetal cardiac activity, such patients under the clinician decision, they underwent DNC and received the product of conception. Now, the image which shows over here, it's a cleaned POC sample where the residual section has been removed. And then we have extracted the POC DNA. Now, before processing it for downstream, we check for the maternal cell contamination using QF-PCR. And when the sample was MCC negative, they were being processed for chromosomal microarray. So we recruited total 30 patients. The POC was evaluated along with the parental karyotype was done. And in 9 cases, we found the maternal cell contamination, which could be due to different factors that the sample handling was not appropriate and there was more of the maternal part over there. So those samples were excluded. Then our remaining samples, 21 samples, were then further taken for the CMA. And we found that 4 were pathogenic variants, and there was 1 likely pathogenic variant. We found 4 VUS variant, and in 12 samples, no CNVs were detected. So this is just a picture of the parental karyotype, where we found that in 5 patients, we found the polymorphic variants. And then there was balanced translocation in one of the male at chromosome 9 and 15, and in one of the female in one of the male at 11, 14, and female at 9 and 15. I'll discuss this later in a slide. And this is the CMA for CNV analysis, which I'll discuss case-wise in further slides. So this was one of the case where we had the patients where the mother was a balanced translocation carrier at chromosome 9 and 15. And this had a history of 3 abortion, and it was the 4th POC which we evaluated. And we found that at chromosome 9, there was a 90.3 MB duplication, and at chromosome 15, there was a 21.3 MB deletion. So this chromosome 9 duplication, it was consistent with partial trisomy 9, and the 15 deletion, it overlaps with the 15q deletion syndrome. So we can say that since the parents were also a carrier for 9 and 15, it suggested that there was some rearrangement at these loci in the fetus. Then there was a next patient where the male was a balanced translocation carrier. And again, we observed that there was a 6.8 MB loss at chromosome 11 and 34.1 MB gain at chromosome 14. So this deletion at chromosome 11 was actually overlapped with the 11q deletion syndrome, which is also known as Jacobson syndrome. Whereas the gain at chromosome 14, it shows partial trisomy of 14q, which is frequent with a low birth weight developmental delay. Again, this pattern of translocation is suggestive because of the parents were carrier for this. Then we had the next sample where there were 5 losses, and there was a 155 MB mosaic gain at chromosome X, which this condition is very much similar to the mosaic Klinefelter. Now, since mosaic was not detected any of the parental karyotype, we suggested that it must be de novo. Again, another couple, we found that there was a gain of 134 MB at chromosome 11, which is a complete trisomy of 11. Now, in this case, you will see that this couple has a normal karyotype, but it has a developmental delay child, a 3rd girl child. And when the karyotype of that child was done, or the subtelomeric MLP was done, they were all found to be normal. So again, this trisomy 11 is an instance likely to be, it's a de novo incidence. Then we found some VOUS also on chromosomes 2, 7, 14, and 17. And there were some OMIUM genes which were being associated with these chromosomes. Among these OMIUM genes, we found that FAM 177A1, it plays a role in TLR signaling pathway, which plays a crucial role in maternal fetal communication. Then we had ERB gene, which plays a role in fetal lungs type cell maturation. Then we have CMG18 gene, which is associated with thyrotoxic periodic paralysis. And then we have PRG4 gene, whose overexpression is seen in apoptotic cell, and it's mainly associated with P53 genes. Now, this is an overall view of all the patients which we have recruited and their karyotypic findings and the POC findings. So ultimately, we concluded that the findings of these studies show that the importance of investigating the role of CNVs in POC samples from the recurrent pregnancy loss patients. And further, these chromosomal abnormalities in couples are considered to be strong etiologies for recurrent abortion. Thus, parental karyotype is strongly recommended in such cases. However, there were certain limitations because the number of CNVs in the genome is so large and it contains large number of genes. Identifying specific genes which are associated with miscarriages is still a challenge. The sample size was not large enough to calculate the correlation of advanced maternal age or the number of number of abortions with RPL. So the takeaway message is, when we're doing the initial evaluation for early RPL cases, if it is the first miscarriage, no action can be taken. But after the second miscarriages, we should definitely go for examine the fetal POC samples. If the karyotype shows aneuploidy, no further evaluation is required. But if the karyotype shows euploidy, then the RPL workup needs to be done. And in case of unbalanced chromosomal translocation, the parental karyotype should be performed, and it will offer pre-implantation genetic diagnosis to the patients. However, the last case, if no CNVs are detected, then we should definitely move forward for the advanced techniques, which includes the cryo-exome sequencing, which is including both the parents and the fetal sample, and the couple exome sequencing. Thank you, everyone.